Good morning, everyone. I welcome you all to this morning clinical presentation of the Young Ophthalmologist Forum. The topic today is the role of antivascular endothelial growth agents in the management of ophthalmic disorders. As we all know, introduction of antivascular endothelial growth factors more than a decade ago has been one of the revolutions in medicine, especially in the management of ophthalmic disorders. So today, Dr. Kasim Mohammad, a senior registrar from National Eye Centre Kaduna, will be taking us through this topic. Thank you very much for accepting this invitation. You have the floor now.
Good morning, my moderator. Good morning, my senior colleagues and colleagues. The topic of discussion today is role of antivascular endothelial agents in the management of ophthalmic disorders. I will follow this outline: introduction, types of anti-VEGF, uses, contraindications, adverse effects, conclusion, and then references. By way of introduction, VEGF is an acronym for vascular endothelial growth factor, which is responsible for growth of blood vessels. It is a compensatory mechanism in case of hypoxia, whereby there is angiogenesis and then formation of new blood vessels. However, despite the good activity of the VEGF, it has also some unwanted effects that we shall see in the course of our discussion. VEGF has a family. Before going to anti-VEGF, we have to have a clear understanding on this. What is this vascular endothelial growth factor? It has a family of VEGF A, B, C, D, E, and F, together with also placental growth factors. Importantly, is the VEGF A, B, and then placental growth factor. The function of VEGF A, as we can see in this table by the left-hand side, is that it promotes angiogenesis, vasodilatation, and also it has chemotactic effect. That means attracting macrophages and then granulocytes. While VEGF B is a promoter of embryonic angiogenesis. VEGF C is for lymphangiogenesis. Likewise, VEGF D and VEGF E is also angiogenesis, and then placental growth factor is for vasculogenesis and inflammation. In this family, some of them has isoforms, some of them do not. It's important for us to know which one is which, because this will now give us a way of better understanding anti-VEGF, the differences between them, and then to appreciate their efficacy. In the table on the right-hand side, you can see that VEGF A has an isoform of about 5 isoforms. We have isoform 206, 189, 165, 145, and 121. While the other VEGFs, they don't have isoforms. These are very important because some of the antivascular endothelial growth factors that we shall see later have they have preference of some of the isoforms and not the others, while others has preference on all of them. And that will now explain the efficacy of the drug. Now, having talked about the vascular endothelial growth factors, where are the sources of this VEGF in the body, or in the eye in particular, sorry, because we're dealing with ophthalmology. At least 5 cells do produce vascular endothelial growth factors in the eye. And these are the RPEs, the astrocytes, molar cells, vascular endothelium, and then the ganglion cells. When these cells, when are these VEGF produced, and what is their mechanism of action? This is what we shall see in the subsequent slide. The VEGF and the angiogenic cascade. The initiator of vascular endothelial secretion of vascular endothelial growth factors solely is hypoxia. So when there is hypoxia, there is stimulation of production of vascular endothelial growth factor and other angiogenic factors in the subretinal space. When these VEGFs are being secreted, the VEGF moves to the vascular endothelium, where they now, the vascular endothelium in the nearby capillaries, where they now promote the proliferation of the cells there, and also release of enzymatic proteases. Now, these enzymes that are being produced alongside with the proliferation of the cell inside the endothelium, the enzymes will now break the basement membrane, thereby allowing a pore, an out opening or out pouching of that endothelium. From that out pouching, the new cells that have been proliferating will now migrate towards that new opening and then try to aggregate and form a new blood vessel. At the end of the day, you'll find out that there is the mother vessel is there, and then there are other new vessels that are being formed. But these new vessels are unlike the original vessels. They lack the capacity and then the good properties of the new vessels with all the layers and then all the supporting mechanisms. Such new vessels, they lack parasites, they lack good collagen supporting structures, and therefore they are so friable, they are so volatile, and then they do leak fluids that are not wanted in the space. So as such, we will find out that there's fluid accumulation in the eye, and then this will now contribute to hazy media if it is in the vitreous, or if it is in the macula, it will now lead to edema of the macula and also subsequently visual depreciation. This is a picture, as we can see. This is a fundal photograph showing the optic disc. Surrounding it are numerous new vessels, and then there are other new vessels elsewhere. As we can see in this picture, there are tortuous blood vessels, and then some of the places are even leaky, simply because they lack parasites, and then they lack that quality of a normal blood vessel that allow smooth passage of blood from the beginning to its destination. So you will find these new vessels are usually leaky, friable, and then they also have more propensity to hemorrhage and leakages. When these things happen in the eye, this leads to significant visual loss or visual decline. And these are the unwanted effects that are being seen in the case of VEGF production, which is a compensatory mechanism due to the hypoxia that has happened in the eye. So, in as much as is good as a compensating mechanism, but scientists now sat down and thought on how to combat this unwanted effect of the VEGF. And therefore, this brings about the drugs that will target this VEGF so as to reduce or even eliminate the unwanted effects of the VEGF. In the year 2004, the first drug that was being introduced and approved by the FDA was, in the year 2004, it was pegaptanib. Pegaptanib is an aptamer, meaning it is a short single RNA strand that binds only to VEGF-A isoform. It does not bind to other VEGF family. It only binds to VEGF-A isoform. And in the VEGF-A, not all the isoform is only one isoform, we shall see later. In the year 2005, a new drug was also introduced, which is the bevacizumab. It is a monoclonal antibody. Monoclonal in the sense that it's produced in the lab, and then made in such a way that it targets only one receptor. It binds to all the VEGF-A isoforms, unlike pegaptanib, which binds to only one isoform of VEGF-A. The bevacizumab has broader activity. that it binds all the VEGF-A isoforms. And that now shows the efficacy of bevacizumab over pegaptanib. In the year 2006, ranibizumab was introduced, which is an antibody fragment. And this one binds also to all the VEGF isoforms, but it has high affinity than VEGF-A. In pharmacology, there is, okay, I will talk about this one in the next slide. The third one is the aflibercept, which is a future protein. It was introduced in 2011 up to 2013. And this one, as we can see, at the binding site, it not only binds the VEGF, but it also encases the VEGF and traps the VEGF and not allowing it to bind to its receptor. Let us be clear that all these anti-VEGF that we're talking about, they usually adhere the VEGF and competitively inhibit the VEGF from attaching itself to its receptor, that it will, if it has attached to it, ab initio, it will trigger that VEGF cascade. So this VEGF will now bind to this anti-VEGF will now bind the VEGF and competitively inhibit their binding towards their receptors on the target tissues, thereby reducing the action of the VEGF. So not only VEGF-A isoforms that aflibercept can encase and trap, but rather all VEGF-B also inclusive, and even the placental growth factor. And this will now be clear to us how aflibercept is superior to all of the three anti-VEGFs. Here we can see in this table, we have the pegaptanib, the ranibizumab, the bevacizumab, and the aflibercept, their structures. This one, as I've said before, this one is an RNA aptamer, while this one is humanized FAB antibody, humanized immunoglobulin B, and artificial protein. In this table, what I want us to focus is, there are two things in the efficacy of a drug in pharmacology, which are the affinity and then the potency. The affinity is how strong these drugs are bound to its targets. So the more the bond, the more the affinity and the efficacy of the drug. While potency simply means the amount of drug that is required to produce a desirable effect. So when you have a large amount of drug that can produce a desirable effect, and then a small amount of drug that will produce a same desirable effect, you can find out that the one with small amount of drug has better efficacy than the one that will have the large amount of drug at the end of the day producing the same results. So in this table, you can see that from the affinity in pegaptanib is 200. Ranibizumab is 9.2 to 179, almost around 200 also. But bevacizumab, the affinity is about 58 to about 4,456. So you can see the big gap between bevacizumab and its predecessors. While aflibercept is between 0.49 to about 9,263. And that becomes very apparent how aflibercept does its action. It has the strongest affinity among all of them. That's why it supersedes them. And in terms of potency, we can see that pegaptanib is 750 to 1,400, while ranibizumab is between 88 to 1,140, so almost similar to pegaptanib. But bevacizumab 500 to 1,476, and now in aflibercept is just 16 to 90. You can see that it's just small amount of aflibercept can trigger same action that is needed, in which the other predecessors, they need to have large amount before they produce similar effect. And this now explains the superiority of aflibercept over the action of the others. The half-life of these drugs are seen in this table. As you can see, in the vitreous, for pegaptanib is 10.4, while ranibizumab 7.2, 6.7, and then there is no study available for aflibercept. And in the plasma, we can also see the systemic route Only bevacizumab and aflibercept have systemic role because bevacizumab, as we can see in later slides, it has been approved for an adjuvant therapy for cancer drugs. Now to start with pegaptanib, it is an FDA approved for treatment of neovascular age-related macular degeneration. It is pegylated antivascular endothelial growth factor, which is an aptamer, as I've explained earlier. It specifically binds to 165 isoforms of VEGF-A only. That means there is a lot of gap because even in the VEGF-A, it only binds the only 165. That means the other receptors are there. When the VEGF are secreted, other isoforms can go and then elicit the action of the VEGF. And now this is a drawback of pegaptanib. The dosage of pegaptanib is usually given 0.3 milligram as a dose once every 6 weeks by intravitreal injection. Following 0.3 milligram dose of the pegaptanib, the half-life is about 20 days, we have seen in the previous table. But this drug has been stopped because it doesn't inhibit VEGF completely, and thus it has a lower efficacy. The other drug, the second one, is the bevacizumab, which is widely used but still not FDA approved in ophthalmology. It is a recombinant humanized monoclonal antibody that blocks angiogenesis by inhibiting all forms of VEGF-A, all isoforms of VEGF-A. It received its approval in 2004 as a standard, as a combination for a standard chemotherapy for metastatic colon cancer. That is what bevacizumab initially was made. So it has also been approved for use in certain lung diseases, renal cancers, ovarian cysts, and glioblastoma multiforme of the brain. So still it is an off-label drug that is being used in ophthalmology because it has been shown, studies have been done that it also has promising results in treatment of many of the ophthalmology diseases that I will explain later. The dosage and administration of bevacizumab, which is the third name, which is the Avastin, it is usually given by transconjunctival intravitreal injection into the posterior segment. And then the intravitreal injection for the retinal pathologists are typically administered 4 to 6 weeks intervals, but although it varies based on the disease and then the response. The dosage is 1.25 milligram in 0.5 ml in adults and half of that in babies. The half-life estimated is 20 days. Ranibizumab, the dosage of administration is that it comes in 10 milligram per ml or 0.5 milligram per ml, but we give 0.05 ml. Ranibizumab also binds to all forms of VEGF-A, as I've said earlier, but with stronger affinity than its predecessors. The half-life is 9 days in the vitreous. Aflibercept is a recombinant fusion protein consisting of VEGF binding portions from extracellular domains of human VEGF receptors 1 and 2 that are fused to the Fc portion of the human hemoglobin 1. The dosage 0.05 ml administered by intravitreal injection 4 weeks monthly. And as we do in our Eye Centre, we usually give each about 3 doses. Then after that one, we do OCT and then fundal photo to see the initially before the giving of the drug, we take the OCT and then the fundal photo to see to serve as a baseline. After giving the drugs, then for 3 shots, then the OCT and the fundal photo is repeated to see the efficacy of the drug. After that, the surgeon will now decide whether to continue or to stop. Its trade name is IDEA. So, having understood about what are the VEGFs and what are the anti-VEGFs, now the uses of anti-VEGF. For easy understanding, it is categorized into 3. We have the posterior segment diseases that VEGF are being used, anti-VEGF are being used. We have the age-related macular degeneration in the posterior segment. Diabetic retinopathy consists of the proliferative diabetic retinopathy and then the macular edema, clinically significant macular edema. Vascular occlusion, retinopathy of prematurity, neovascular glaucoma, idiopathic polypoidal choroidal neovascularization, choroidal vasculopathy, sorry, and Koch disease, etc. There are many. In the anterior segment, also, anti-VEGF are used in cases of pterygium and corneal vascularization following PKP, corneal vascularization following chemical burns, also corneal vascularization following herpetic stromal keratitis, or even Steven-Johnson syndrome. Also, anti-VEGFs can be used as an adjuvant therapy with some surgical procedures, like phacoemulsification in clinically significant macular edema, PPV in PDR and non-clearing vitreous hemorrhage, and also in glaucoma surgery. All these things, there are a variety of literatures that have been done in order to support these findings. I don't think this time is enough for us to take each and every entity of this one and talk about all the literature or all the research, the studies that have been done, because each one of them can have variety of studies and on each entity. However, there are evidence that will back all these summarized conditions that I've said. As an example, some of them like that are not commonly seen here in our practice, like in case of pterygium, we can give typical anti-VEGF in pterygium. And then what has been studied, like in this study, they use topical bevacizumab, which is Avastin, 25 milligram QDS, dosing for 3 weeks. In a case of recurrent impending pterygium, it prevents recurrence for up to 6 months. We can see in the first picture from the left, this is why pterygium is there. And then after 14 days, and look, we can appreciate how the pterygium has shrunken. This now explains the potency of anti-VEGF in terms of pterygium treatment. Also, we can also give subconjunctival anti-VEGF. And it's in this picture, as you can see, they used bevacizumab, which is Avastin 1.4 milligram or 0.05 ml, which causes regression of vascularity. Symptoms like irritation and redness are also subsided up to 7 weeks. We can see in the first picture how the pterygium is, and then after the subconj injection of the bevacizumab, look at how it has regressed in 3 weeks. Following chemical bonds, anti-VEGF role in preventing neovascularization and accelerating repair has been demonstrated in animal models. There's a study on this one. In this picture, we can see that this is the chemical, this is A, B, C, D, E, F. From the first insult after alkali bond, the first day, the day 3, and then the 7th day, that's why you start finding neovascularization. But when bevacizumab was introduced, as we can see in the picture E, which is at the top right-hand corner, this neovascularization has started reducing slightly until when you see F and G, you can almost see there is no new vessels. That is to show the efficacy of bevacizumab. In herpetic stromal keratitis also, there has been study whereby intrastromal anti-VEGF was being used, and then following the corneal neovascularization, and it has been seen that it has also reduced significantly. As you can see, I don't know, this one is not that clear. In the left-hand side, where from my end I can see some new vessels, and then in the right-hand side, it is somehow cleared off. So all this one explains the effects and the importance of anti-VEGF. There are also many evidences from literature that anti-VEGF are used for neovascular glaucoma. This is just a summary. They found out that the effective way to give anti-VEGF in neovascular glaucoma is intracameral, and then they found out that the anti-VEGF plus trabecular plus trap, anti-VEGF plus trap is better than giving armored glaucoma valve alone in neovascular glaucoma. Another study done is that they found out that armored glaucoma valve plus anti-VEGF is better than anti-VEGF alone in neovascular glaucoma. Now, what are in as much as anti-VEGF are important, but and then we have seen the indications of giving anti-VEGF, but there are some contraindications to which anti-VEGF are not supposed to be given, because they have some adverse effects that will worsen the scenario if given in such patients. Example is somebody with stroke, cardiac arrest, or uncontrolled hypertension, or somebody who is on anticoagulants. These ones, they are contraindicated for anti-VEGF. What are the adverse effects of anti-VEGF if given in high doses or long term? We have ocular and systemic. In ocular side effects, they found that there is infectious endophthalmitis remains one of the most devastating complications of intravitreal injections. In a multi-center clinical trials with anti-VEGF therapy, the incidence of endophthalmitis per patient has been reported to range of 0.019 to 1.6%. Also, intraocular inflammation from about 1.4 to 2.9%. Rheumatological retinal detachment is low, 0 to 0.67%. Subconjunctival hemorrhage has been reported to occur in nearly 10% of injections, with higher frequency in patients who were receiving aspirin. There is also a tendency of increase in IOP. These are the adverse effects, ocular adverse effects for anti-VEGF. What are the systemic side effects? Intraocular injection of ranibizumab was linked to a significant increase in non-ocular hemorrhagic events, including ecchymosis, GIT hemorrhages, hematoma, vaginal hemorrhages, and subdural hematomas. The rate of any cause of death, myocardial infection, and cerebrovascular events were not significantly increased. However, even if they are not significantly increased, there is the retrospective study of about 1,173 patients receiving bevacizumab injections. The reported systemic events included acute blood pressure elevations of 0.59%, cerebrovascular accident of 0.5%, myocardial infection of 0.4%, iliac artery aneurysm of about 0.17%, and also 5 deaths. So this is in short pertaining VEGF, the VEGF family, the anti-VEGF, their types, and then their uses, their complications, and the adverse effects. And these are some of my references. And thank you for listening.
Thank you very much, Dr. Kasim Mohammad, for this very enlightening presentation. So I'll pause now to accept to take questions.